This is the second edition of our mechanical thrombectomy for acute ischemic stroke implementation guide. Few minor housekeeping issues. We suggest you keep your switch your video feed off unless you're presenting or speaking, but we'll be asking people to post questions for the panel discussions in the chat throughout the webinar. So you can do that throughout the webinar and we will pick those up. The meeting will be recorded, so another reason you might want to just turn your video off, and a recording will be shared shortly after the webinar. Have the next slide, Martin. And so the guide is an update of a number of chapters from the first edition, and we're grateful to our authors and co-authors who updated those, and a new chapter on the issues of delivering thrombectomy during the COVID-19 pandemic. The agenda is as there. We've got two Q&A sessions, first after three presentations from two of my co-editors, Phil White, Martin James, and one from Alex Mortimer, and second from David Hargrove. So after those four presentations, we'll have a Q&A session, a short break, and then the second half will be experience of how a number of centres, Royal London, Wickham and Queen's, found the first edition of Views, followed by another Q&A session. So with that, I'll start with introduction from Sir Bob Neal, Chair of the All Parliamentary Group on Stroke. Sir Bob is, as recorded in advance of the meeting, can't be with us today, so we will move to play his introduction.
Hello, my name's Sir Bob Neal. I'm the chair of the All-Party Parliamentary Group on Stroke. I founded that with some other colleagues from both the House of Commons and the House of Lords because of our own family and personal experiences of stroke. In my case, my wife Anne Louise had a stroke back in 2019. It was life-changing for her. It ended her career as a professional singer and performer. And of course, we as a family have had to cope with both the treatment and then the rehabilitation thereafter. What we also found, of course, is that we were far from alone in that. Stroke, in fact, is the fourth biggest killer in the United Kingdom. It's the largest single cause of adult disability. Someone has one every 5 minutes or so. So it touches so many of us. And that's why we wanted to raise the attention and the profile that stroke gets in Parliament and the political world, because it doesn't get as much attention as it should in our judgment. It doesn't get as much attention perhaps as cancer or Alzheimer's or many other things. And we're working with the Stroke Association and others to try and improve that. One of the things that we have done is that we think we've succeeded in making people more aware of the symptoms of stroke. But when we get there, despite our brilliant healthcare professionals, there's still things that we should be investing in to give people a better chance, not just of surviving, but also of reducing their disability. And that's where mechanical thrombectomy comes in. If there is anything like a silver bullet, mechanical thrombectomy gets pretty close to it. Because by using that simple stent, as you know, to remove the clots and blood from the brain, that can significantly reduce the amount of impairment that stroke victims are left with afterwards. And that, of course, enables them to have a much better and fuller lifestyle and to be less of a demand upon public services. It actually is reckoned, you know, that using mechanical thrombectomy by reducing the disability that people get can save about £47,000 per patient. I mean, in a sense, the money doesn't matter, but it is important to the health service. But it also gives them and their families a much better hope of a fuller and happier and richer life as they recover. So we're supporting the campaign to increase the rollout of mechanical thrombectomy in the United Kingdom. We've stagnated on that. We haven't made the progress that we should have done since about 2013. And at the moment, it's offered in only about 2.4% of cases, as opposed to the NHS's own target of 10%. And we don't do as well, I'm afraid, as some of our neighbours in that regard. In Germany, they've already reached 8%, and in some other European countries, they get up as far as 22%. So I'm very happy to support the initiative that's being carried out and to introduce this video, and I hope you'll be interested in the seminar that's going to follow, because rolling out mechanical thrombectomy is really important and can make a life-changing difference to tens of thousands of people. It's worthwhile, and I hope that you'll do all you can in your organisations to encourage the uptake of mechanical thrombectomy. We in Parliament will be doing our bit to press governments to do the same and invest in it properly to the level that people deserve to have in an advanced Western democracy.
We're grateful to Sir Bob for that introduction, and I'll now introduce our first speaker on an update from the guide. So this is my colleague Phil White, and co-editor from Newcastle, who's going to give an update to the evidence for mechanical thrombectomy. Thanks, Phil.
Thanks, Gary. So I'm going to give an update, and really I'm going to restrict it. I've only got 10 minutes to reviewing some key randomized control trial evidence that has been published since the last guide in 2019. So it's really just the last 2 years worth, if you like, of evidence from randomized trials that's directly relevant to thrombectomy delivery and implementation. So the first of these is direct thrombectomy. Then a look at the RaceCAT Japan limit trial, which is looking at low aspects thrombectomy in people with perhaps larger strokes. And then finally, a few words on the RaceCAT trial, which is looking at the concept of mothership and redirecting ambulances rather than the conventional drip and ship with secondary transfer as a paradigm of care. So those are the three areas I'm going to look at. This is my statement of interests, mostly not relevant to this talk, except I was a member of the ESO ESMINT Working Party on guidelines for direct thrombectomy, which I'm about to talk about. So we now have 6 randomized controlled trials that have reported in this area, 4 fully published, 2 with detailed conference presentations. All 6 trials were randomizing patients who were direct admissions to a thrombectomy unit, a comprehensive stroke center, or CSC. So these trial data do not apply to drip and ship patients. In terms of the quality of the trials and the risk of bias, we assessed those using the sort of standard methodology of the Cochrane collaboration, and 3 of the trials running in Europe and North America were adjudged to be a very low risk of any bias. 1 Chinese trial was felt to be at high risk of bias, and 2 there were some concerns, but not too great. 1 from Japan and 1 from China. We published this meta-analysis, which accompanied our guidelines, in both the Journal of Neurointerventional Surgery, BMJ journal, it's usually open access online, and the European Stroke Journal in February this year. And this first forest plot shows the impact in terms of ranking 0 to 2 outcomes. So this is a clinical outcome of functional independence at 90 days. On a forest plot, the odds ratio of 1 would be no difference at all. And where the bars overlap 1, it means there's no statistically significant difference. There may be trends, but no statistical difference. And that's what we find for ranking 0 to 2. The plot overall, and this is nearly 2,300 patients, trends to favor in the combined approach, IV thrombolysis as bridging plus thrombectomy, and the odds ratio for that is 0.93. So a small trend to favoring the combined approach in terms of functional independence, but not a statistical difference. But when we looked at non-inferiority, none of the trials, when you added them all together, the trials did not meet non-inferiority criteria for direct And that was at both a level of 1.3%, judged the minimum clinically important difference, and also with regard to a 5% difference. So we're a little bit more generous, and even at the 5% level, non-inferiority was not demonstrated. There was a difference between the two groups in terms of reperfusion outcome, good to excellent reperfusion as assessed by the thrombolysis and cerebral infarction scale, or the TICI 2B or 3. This is the TICI 2B3 result overall. We see it is separated the box from the odds ratio 1, odds ratio 0.72, a statistically significant difference in favor of reperfusion for the combined approach. What about safety? Because one of the reasons direct thrombectomy has been proposed is without thrombolysis on board, it would be safer as well as quicker. There was no difference in timelines that we could find with either approach overall, but in terms of 90-day mortality, we find that the odds ratio is 1.06, slight trend again to favor the combined approach over thrombectomy alone. So no statistical difference, but if anything, small trend to lower mortality with combined. So no reason to really change advice there. Finally, symptomatic intracerebral hemorrhage. Here, unsurprisingly, there is a stronger trend favoring thrombectomy alone because, of course, there's no thrombolysis on board with the patient. And so the risks of ICH with thrombolysis are taken out of the equation, but it doesn't reach, despite 2,300 patients, a statistically significant difference between the two arms. So a trend, unsurprising trend, and in fact, any ICH is statistically lower with thrombectomy, direct thrombectomy alone, but not symptomatic ICH, which is what most of us regard as the important criteria. So we issued guidelines, the working party using the grade methodology for assessing this, and really it's no change. If the patient's got an acute ischemic large vessel occlusive stroke in the anterior circulation, presenting within the time window for thrombolysis and eligible for it, they should get that as well as thrombectomy. Neither treatment should delay the other. Again, no change. The quality of evidence we assessed as moderate on the grade methodology, even though it's multiple RCTs. Strength recommendation was strong. Similarly, we didn't have such high quality evidence for patients presenting to a non-thrombectomy capable center. So the evidence here, quality here is low, but again, a strong recommendation that patients, if eligible for both, should have both treatments. So they should get IVT before transfer, i.e. drip and ship should continue on that basis. Likewise for wake-up stroke patients, if they meet the already published ESO guidance for wake-up stroke thrombolysis, then they should get both again. So that's moving on to next randomized control trial to look at is this one, Rescue Japan Limit, which was just published a few days ago in the New England Journal of Medicine. And this looked at thrombectomy in low aspect stroke. Now I put that in inverted commas for a reason I'll explain later. This trial looks very promising. They found that thrombectomy was significantly better than standard medical care. The absolute benefit for a ranking 0 to 3. Now this is 0 to 3, not 0 to 2. Most of the previous thrombectomy trials have looked at 0 to 2. This is 0 to 3 is 18% absolute benefit, but the sort of order that we saw with other trials for 0 to 2. And the ordinal shift analysis of the ranking also favors thrombectomy. Odds ratio is shown there, 2.4. And again, there were no major safety concerns over thrombectomy in low aspect stroke. Any ICH was increased, as I just showed for direct to MT, but again, not symptomatic ICH. So all good news. And this is the Grotter plot of the endovascular group against the best medical care group, seeing the shift. But what you should notice is the shift here is mostly from 5 and 6 to 4 and 3. So there are very few ranking 0, 1 or 2s achieved in this low aspects group patients. So we're mostly shifting people from dead to moderately disabled. Some people would be more or less happy with that. And most people would be happy with shifting from severe to moderate disability, say 5 or 4 to 3. So that's mostly what we're achieving in this trial. However, there are some quite important specific issues about the trial to be aware of. We looked at this, I'm a member, as I mentioned in my declaration of interest, a member of the Tension Data Monitoring Committee, and we were asked by the steering committee to look at this data, should Tension continue to randomize low aspect patients. And I know there are other ongoing trials that have done so as well. and they've all continued to randomize. And these issues are multiple. One of them is that the trial used actually MRI-based aspects in almost 90% of the patients. And typically DWI aspect scores lower than CT aspects. So if you normally screen your stroke patients with CT aspects, a CT scan, not an MR scan, then the data from this trial need to be taken with a very large pinch of salt, because the aspects, most of them were 4 or 5 for MRI, which translates into CT aspects of 5 or 6. And we already know that CT aspects of 5 and 6 is not really truly low. And the Hermes collaboration had already published in the Lancet Neurology in 2019 that there was proven benefit for thrombectomy for his CT aspects of 5 as well as 6 and up. So a lot of the patients in low aspects trial here were not truly low CT aspects, but lower mid to low MR aspects, and they're not the same thing. It's a small single trial of 200 patients, quite a number of which were excluded after randomization. So although they're in the ITT analysis, they exclude quite a lot in the per protocol, more than is usual for a randomized controlled trial. There are some modest group imbalances, occlusion site, infarct volume, 17% greater in the medical group over the thrombectomy group at the time of randomization, etc. There were low rates of IVT use in this trial across the board, and because it was in Japan, again, not at a dose of thrombolysis that is typically used in Europe and North America. And then there were some key subgroups, and I'll show the subgroup in that forest plot in a second, with a non-significant trend to benefit. So trends, but not statistical significance in some subgroups that are quite important. And again, as I alluded to already, excellent and functional independent outcomes were similar. There are very few ranking 0, 1, or even 2 results in this trial. So all of these trials, including the one I'm involved with, are continuing to randomize, thinking that actually a lot of this data does not apply to the patient population. They're actually enrolling low CT aspects. That's the subgroups. Some of them, the confidence intervals overlap, they know difference. So they're trend, but not statistically significant differences. And important groups of patients, the under 75s, those who present a bit later, and those who've had TPA. So there's some unresolved uncertainties, but the results are encouraging. Finally, I'm going to finish off 1 minute on the RaceCAT trial. This was a trial of ambulance bypass, taking a patient direct to a comprehensive stroke center in Barcelona, in Catalonia in Spain, rather than taking it to local primary stroke center. It was presented more than a year ago at ESOC, but is yet to be published in full, which is a little unusual. It didn't improve outcomes. The bypass model, or if you like, mothership, the adjusted hazard ratio was 1.02 on shift analysis of the ranking. So not proven superior, and it applied to the group enrolled in that trial, which was those whose nearest acute stroke center was between 20 and 150 minutes by ground-based ambulance from a thrombectomy center in Barcelona. There are a lot of issues with this trial. I don't want to dwell on them. I've just listed some of them here. Particularly important is they had exceptionally good door in, door out, or DIDO times in RaceCAT. You'll hear more about that from Martin James shortly, about door in, door out times, but they're a lot worse than the NHS, so that this trial result of RaceCAT with really good door in, door out times may not apply in the NHS. There are also some other issues about imbalances between groups, but also very high mortality rates that are yet to be explained, and we wait the full publication. But again, indicates no change to practice. Strip and ship seems appropriate at the moment, mothership not proven to be better. So my take-home points: thrombolysis should be continued to be given in addition to thrombectomy where eligible for both. Direct to MT is safe, but it's not statistically proven as non-inferior, certainly not superior. There are no safety concerns with it though. Further trials are required, I think, before changing practice. I don't think the Japan limit trial on its own should change our practice yet. The mothership, we'll wait more data and more information from RaceCAT. Its full publication will be very interesting. So some new updates and some food for thought there. So thank you very much for your attention and for joining the webinar this evening.
Thank you, Phil. Please put any questions you have in the chat, and I'll pick them up when we get into the panel discussion. Our next speaker is Martin James, other co-editor of the guide, and from the NHR Applied Research Collaborative in Southwest Peninsula. And Martin's going to give an overview of update on how many patients need mechanical thrombectomy and how best it's delivered. Thanks, Martin.
Many thanks, Gary, and thank you all for joining us this afternoon. I'm going to be talking about, as Gary said, about how we might go about delivering mechanical thrombectomy to as many people as we can. And I'm just going to make sure that my ability to advance the slides is still working. It looks as if I've got control of the screen, doesn't it, Martin Lever? But my advancing function isn't working. We might have to do a Chris Whitty, mightn't we, Martin? You might have to.
I'm happy to do. Yeah, I'm happy
take
to
back
do
control, and I'll ask for the next slide. That's probably the quickest way to a smooth transition. So, of course, since our original publication, Gary, Phil, and myself and colleagues in 2016, we've been working on this assumption that it's about 10% of all stroke that would be eligible for thrombectomy. So let's have a quick look at how that might have changed given the developing evidence, some of which Phil has already alluded to. Next slide, please. We're about to go into print with an updated version of the numbers paper in the European Stroke Journal. And there are some things that have changed since 2016. For a start, we're more confident about the proportion of all strokes which are represented by large artery strokes. And we've settled on a figure of about 35% from large published series. So that means of all the 95,500 patients admitted to stroke in the UK admitted with stroke in the UK, we've got about 29,000 large artery strokes. And then if you follow this pattern down the left-hand side of your screen, you'll see that for the majority of people who present early and who are, because they're presenting early, eligible for IV thrombolysis, they provide the majority of about 8,500 to 9,500 patients eligible for thrombectomy. If you could move on to the next slide. But what about, oh no, go back one, please. It was those transitions that I wanted, those extra boxes. So if we look at the use of advanced imaging for patient selection, and of course, that's the logical basis behind a lot of the publications looking at the expanded eligibility of patients for thrombectomy. Obviously, their main use is in the group of patients who present too late for thrombolysis, and to select those with a salvageable penumbra as per NICE recommendations and as per the evidence principally that comes from Dawn and Diffuse. And with advanced imaging, what it does is it finds a group of patients from among those late presenters who are eligible to proceed to thrombectomy, and also if it were applied to the early presenters, finds a relatively small number of the early presenters where, despite the fact they're in hospital early, it's already demonstrated that there's a large and unsalvageable core, and it reduces the early presenters by a small number, by about 500 patients in the UK, and adds about 1,300 patients who are selected from among those who are late presenters. So in the end, altogether, about 14% of patients would have their management altered if we used advanced imaging for everybody. And if we used it to identify late presenters who would be eligible for thrombectomy, that would mean about 1 in 8 of our overall thrombectomy numbers comes from those who are presenting late or with an unknown time of onset. But of course, that is the state of play as it is at the moment. If we consider that in this flow diagram, there are about 6,000 patients with a large artery occlusion, but who've only got a mild stroke, an NIHSS of 6 or below, if we were to find that those patients were also eligible for thrombectomy, and of course there's randomized trials going on in those patients, then the numbers would expand significantly. And of course, if we found that late presenting patients, the criteria used in Dawn and Diffuse were too restrictive, and there was a larger group of late presenting patients who could also be eligible for thrombectomy, there would be a similar large increment in the percentage of patients that might be eligible. We might be talking there about 14% of all patients being eligible, or even upwards. And as we've heard from Sir Bob, there are some sites who are clearly using a fairly liberal selection criteria to identify those who are already eligible for thrombectomy. So next slide, please, Martin. So how's that been going in the UK over the last 6 years? This is, of course, SNAP data showing the accumulation over the last 6 years in patients receiving thrombectomy, 2020 to 21. During the pandemic, growth stalled to some extent, and the overall figure for the year was 2%. We're hoping and expecting to see that higher in 21 to 22. Perhaps we'll get to 2.4 or 2.5%. So there's still a good long way to go. And as you've heard, our anticipated eligibility is at least 10, maybe 11%. And it's feasible. There are sites in not so distance, the Republic of Ireland, for example, and also Germany, who are hitting 8 or 9%. And obviously there are published series, perhaps rather favorably reporting from Europe, higher percentages than that. So I think we should regard that figure as realistic and achievable, but we're only getting there very slowly. If we go to the next slide, we'll see that over the course of this year, 21 to 22, while thrombolysis remains stuck at about 10.5%, we've seen a gradual but persistent increase to a figure in January of this year of 2.6%. Next slide, please. But of course, the overall activity in the UK as a whole it conceals a substantial amount of variation between sites, both in the overall numbers that are done between our 26 thrombectomy sites in the UK, but also perhaps you can appreciate this from this graph in the proportion of those patients that are represented by transferred patients rather than patients first presenting to the comprehensive centre. So we've got Charing Cross here at the top, who not only are doing the most in the country, but have the highest proportion of their patients are represented by transfers from other sites. Whereas you might look at a place like Addenbrooke's lower down the scale, which is not taking any referrals from elsewhere at all. And then if we move on to the next slide, the other significant variation, of course, is in how quickly thrombectomy is done. And that's the other element of the overall health of a thrombectomy network at large, not just what goes on in the comprehensive centre. We know from 20 to 21 that the national average door in, door out time is 2 hours, 18 minutes, a little bit higher than the year before, in fact, when it was 2 hours, 10 minutes. And there's big variation. The best Dido time last year was among a relatively small number of patients who were transferred to Hull at 1 hour, 28 minutes. So we know it's possible to get down to an hour or an hour and a half, and that should certainly be our objective and our target, increasing the number of people who come from referring centres and shortening their door in, door out time. Next slide, please, Martin. If we look at what's going on at the moment, about half of all patients in England, Wales, and Northern Ireland who receive a thrombectomy actually come from referring sites, despite the fact that 3/4 of all patients with stroke present to those acute stroke centres, those referring sites. So we've certainly got work to do with networks of thrombectomy centres and their referring sites to ensure that that proportion more accurately reflects the proportion of patients who are presenting to those sites. Next slide, please, Martin. Obviously, you might be tempted when you look at those figures to think about a mothership model, and Phil's talked a little bit about that already. If we simply took a raw decision about the best potential outcome for the patient in the back of an ambulance, then instead of the 27% of the population that you see in the left-hand panel here, for whom a comprehensive stroke centre is their nearest hospital, their nearest acute stroke site, with their red catchments around them, then actually we'd see 94% of the population just heading straight to a comprehensive stroke centre in the hope of achieving a better outcome for their patient. And of course, that would create an unmanageable demand on a much smaller number of hospitals. So if we go to the next slide. But let's be clear, in so doing, that policy would confer a greater benefit to patients. If you look at the left-hand panel here, the blue line indicates how much more quickly a patient would receive a thrombectomy if they were to be transported direct to a comprehensive stroke centre rather than via their nearest drip and ship centre, at the cost of only a relatively modest delay in those receiving thrombolysis. And on the right-hand panel, you do see a significant increment in the overall population benefit from reperfusion. And of course, that's the motivation behind things like the European recommendation that a bypass policy of about 30 minutes is desirable. But if we look at the coloured panel on the right, we see that a 30-minute bypass policy would lead to a massive growth in the blue section of the graph, where hospitals either have no admissions at all or a very small handful, and a similar growth in centres admitting several thousand patients per year. So if we move on to the next slide, and of course there are winners and losers in such a direct bypass policy. If you look on the right-hand blue map, you can see a reiteration of that earlier map showing those who benefit from going directly to a comprehensive stroke centre. But on the left, the rather more pinkish colours show that there is a penalty to be paid for not just for those who receive thrombolysis at a later point, but of course those patients who are displaced away from their own local acute centre who were never candidates for thrombectomy at all. And of course, that's about 80% of all patients in our most optimistic expectations. So if we move on to the next slide. So what we'd like to do, of course, is to be able to select correctly in the pre-hospital phase those patients who should go direct and those who should be transported to their nearest centre. And you'll see the effect on the left on admission numbers to acute stroke centres, and on the right, admission numbers to comprehensive stroke centres from a variety of policies, beginning with drip and ship, of course, which reflects the situation at the moment, and a transition to mothership, which would, of course, wipe out all admissions to acute stroke centres and lead to huge numbers, up to 7,000 patients per year being directed to just the 26 comprehensive centres. And as Phil has alluded to, the RaceCAT test is itself insufficiently specific to mitigate that effect. It reduces admissions, drip and ship admissions, but also leads to a rather unselective bias towards transportation towards comprehensive stroke centres. Whereas a system such as the Stockholm triage system increases the specificity and blunts those exaggerated effects of the redirection of patients, but at some cost, in the sense that in the Stockholm trial, a third of all those patients who received thrombectomy were still drip and ship patients. In other words, it was selective, but not selective enough. So, and of course, the perfect diagnostic strikes the right balance between those two competing priorities, between not overwhelming comprehensive stroke centres and redirecting people, those who would benefit the most. But even then, with that perfect diagnostic tool, we must anticipate that our comprehensive stroke centres will see their admissions rise dramatically to a mean of 1,700, and in some examples outside London, up to 3,500 or nearly 3,500 strokes plus mimics. And so there will still be substantial growth, even if we get very good at selecting those for whom thrombectomy is appropriate. So in my final slide, I just draw some attention to some of the things that we should be thinking about when we're talking about how many patients and where they should be treated in terms of strategies to maximize the population benefit. We've learned that we shouldn't be wasting time doing advanced imaging on early presenters and those who are eligible for thrombolysis. But relatively little of the overall population benefit from thrombectomy will come from relatively small numbers of late presenting patients. We should have a clear objective to achieve those sort of Catalonian Dido times, and we should be delivering thrombolysis and getting the patient back out the door to their comprehensive stroke centre within an hour or less, ideally. And we should be doing that at least an hour earlier than we are at the moment. There's probably very little logic in an ambulance going in a large conurbation, traveling to a relatively adjacent large centre. So, for example, places like Bristol are reconfiguring because it's only 3 miles between their acute stroke centres, and all that you do if you go to the acute stroke centre is simply to delay the delivery of thrombectomy. And also, and we haven't gone into much detail about this, but we've reported on this for NHS England, should be looking at developing new thrombectomy capacity in areas that are poorly served at the moment. And if we are going to use a pre-hospital diagnostic, we're going to need one that still has both very high sensitivity and specificity, as the disruption to the system would otherwise be unsustainable. And it doesn't look like we have that instrument yet. So that's all I've got to say on the topic, Gary, and thank you for listening.
Thank you very much, Martin. Again, I encourage you to ask any questions you have to Martin in the chat. Our next talk is from Alex Mortimer, interventional neuroradiologist at Bristol, and is going to give an update on imaging and the role of AI. Thanks, Alex.
Well, thanks for inviting me to talk today. My name is Alex Mortimer, and I'm an interventional neuroradiologist from Bristol. I'm involved in delivering thrombectomy in the Severn region. I'll be discussing the use of imaging mechanical thrombectomy, in which I'll describe some UK-focused challenges and solutions, including the use of automated imaging analysis and how this could fit into a more streamlined imaging pathway in the future. So for those who are unfamiliar with how patients are selected for mechanical thrombectomy, it's fair to say that imaging plays a vital role for a number of reasons. Firstly, it allows us to identify the site of occlusion and a target for thrombectomy, both intracranially and cervically, and CT angiography forms is the workhorse examination for this. It also allows us to assess the degree of baseline ischemic injury, the amount of core infarction, and that can be done through assessment of the non-contrast CT, through re-windowing the CT angiogram to look at the source images, and also to assess the collateral flow to the ischemic territory using CT angiography. We can also use CT perfusion to get a more visually identifiable assessment of the baseline core infarction, and also to estimate the penumbra, that is the tissue that will go on to infarct if no recanalization is achieved. So both identifying the site of occlusion and the degree of baseline infarction is important for a number of reasons, including targeting treatment to the correct patients to minimize futile recanalization, which in itself may be harmful, and also to limit unnecessary demand on secondary transfer ambulance services. With more widespread use of CT angiography, it's likely that the number of patients who might not necessarily have been selected on the basis of an initial clinical presentation may then benefit from early diagnosis and referral for thrombectomy. And typically this scenario is seen in patients with basilar occlusions who may present in confusing ways, and it's often initially frequently misdiagnosed. It's important to highlight that the majority of patients undergoing mechanical thrombectomy present to acute stroke centres rather than directly to comprehensive stroke centres who deliver thrombectomy. So in the Severn region where I work, only about 16% of patients present directly to the comprehensive stroke centre at North Bristol, with the majority being referred through drip and ship and or hub and spoke models from other centres. As a result, the majority of the initial diagnostic imaging is performed in acute stroke centres, and this is where there needs to be a push to implement more efficient stroke imaging pathways. So it's well recognised that the time to recanalisation significantly impacts on patient outcome and door in, door out time. in referring centres is likely to be one of the most modifiable delays when trying to reduce time to treatment. There are a number of steps that can occur in the acute stroke centre as the patient presents with ischemic stroke symptoms, including a clinical assessment, imaging, delivery of thrombolytic therapy, and when the time and then the time taken to wait for a secondary transfer. If we look specifically at the processes around imaging in systems that are not set up to deliver rapid initial assessment, there can be multiple delays. For example, there may be an initial clinical assessment by one of the ED doctors as the patient presents to the majors or rhesus area, and a CT scan may be organised. The patient is then transferred to radiology and undergoes a CT scan. They are then transferred back to the emergency department. The stroke team is then contacted. The patient undergoes a further clinical assessment where a large vessel occlusive stroke is suspected, and then they are transferred back to radiology for a CT angiogram. The imaging is acquired after discussion with the on-call radiologist. They then transferred back to the emergency department. As the scan report is awaited, there may be problems with imaging transfer to the comprehensive stroke centre, and then a discussion is required with the comprehensive stroke centre to ensure the patient is clinically and radiologically appropriate for thrombectomy. This sort of pathway may seem long, clunky and inefficient, but this is an all too frequent occurrence and explains why, although we're aiming for a door-in, door-out time of less than 60 minutes, more realistically, door-in, door-out times can be 2.5 to 3 hours long. Delays to CTA significantly impact on patients in our experience, and all too frequently this can govern whether a patient is eventually offered thrombectomy. In this example, the patient was initially imaged at 11 AM with non-contrast CT, and by the time they'd had a senior review and CTA organised, scanned with CTA at 2 PM, there is now a large baseline core infarct, which significantly diminishes the chance of a good outcome from thrombectomy. And this sort of problem, in my opinion, is more important and likely more immediately modifiable in the shortage of neurointerventionists, which is commonly argued as the dominant barrier to thrombectomy. And this represents a significant area for quality improvement. The challenge since 2015 has been to implement CTA, and in some cases more advanced imaging like CT perfusion, in a more widespread manner. I think overall in clinical practice, timely access to CTA in acute stroke centres has significantly improved. However, accepting recent strain on the ambulance service, our experience in rolling governance meetings is of consistent delays in imaging acquisition, interpretation and transfer. For this reason, I think it's becoming clear that the role of the initial imaging as part of a focused rapid assessment pathway needs to be developed, where more emphasis needs to be placed on having personnel present who can decision make at the front door and who can drive patients through clinical and radiological assessment in a more timely manner. To facilitate a more streamlined pathway, it may be reasonable to extend pre-alerts from the ambulance service to include wake-up strokes and strokes presenting beyond 4.5 hours. Patients could be assessed by a stroke physician or stroke nurse practitioner at the front door, and if large vessel occlusion is suspected, then simultaneous non-contrast CTA, and if necessary, CT perfusion can be performed. Many hospitals don't currently have the application or expertise to develop CT perfusion, but I think it's changing, but this is changing as scanners are being upgraded, and the use of automated programs makes post-processing and interpretation easier. In many instances, patients can probably be transferred on the basis of favourable CTA, with CTA collaterals being used as a guide. And what we've done with many of our referring sites is to add an additional phase to the local CTA protocols, allowing us to more confidently exclude malignant collateral patterns that are often more commonly associated with poor outcome despite thrombectomy. Image transfer represents another factor which can significantly delay decision-making. In the past, we've relied on web packs access, but this is fraught with problems including password resets and technical incompatibility after upgrades or operating system changes. IEP transfer can be very slow, building in another delay, but once the images have arrived on the host pack system, it does allow for accurate post-processing. We've had most success with dedicated cloud-based systems with automated upload of all stroke imaging to a region-wide viewer financed by all trusts in the network. Although potential for post-processing on the cloud is modest, it allows for initial decision-making and has been linked to the automated assessment tools to allow for initial AI assessment post-referral. Traditionally, widespread use of CT angiography has been met with some resistance by radiology in acute stroke centres, sometimes due to lack of departmental expertise, particularly out of hours, but also because of resource implications, as this adds to the persistent strain on imaging departments. Potential solutions in the future include construction of more robust image sharing and regional image sharing networks to allow for off-site reporting by subspecialist radiologists. And also, particularly out of hours, a solution is for outsourced reporting by subspecialist radiologists or by radiologists who have undergone specific training in CTA interpretation. There may be a way, a case in the future for directing out-of-hours stroke imaging to a specific provider who is able to guarantee a high level of expertise. Independent local imaging interpretation is going to gain increasing importance as more networks push to deliver 24/7 mechanical thrombectomy. It's achievable through both outsourced radiological assessment, local expertise, but also automated systems. I've included as an example here our Brainomics e-stroke system showing identification of dense clot in the right M1, core infarction in 4 aspect segments and regions. These are shown in red, and the system is also able to, the majority of the time, identify proximal intracranial occlusions. Potential advantages of an automated system such as Brainomics or Rapid include speeding up the referral pathway through identification of sites of occlusion and estimating the extent of infarction. They can allow the information required for a stroke physician to make a referral in conjunction with the clinical information. And in busy acute stroke centres, it may allow referral before a radiology report is available. The bonuses are also seen in image sharing, as many systems include cloud-based viewers for or applications. There is potential for pre-alert systems that identify large vessel occlusions, and also with automated post-processing of perfusion imaging, this could become less daunting in non-specialist departments, and CTP may become more widespread. We do need to exercise some caution. However, none of the tools is universally infallible, and here is just an example from a recent case that I treated, the patient with a terminal carotid and M1, M2 occlusion that failed to be flagged by our system. So I think a pragmatic protocol that could be used to include, that could be instituted, could include a primary survey using automated systems whereby a stroke physician could obtain a rapid report from an AI system and act on it if positive for a target occlusion. For those reports that come back negative from the AI analysis, those patients could be flagged for a more urgent radiological review, either by a network subspecialist or an outsourced subspecialist, to ensure that no target has been missed by the AI system as part of the secondary survey. So ironically, it's the patients that I think are flagged as negative by the AI system who should perhaps have a more urgent radiological review. Thank you very much for your attention, and happy to answer any questions.
Great. Thanks for that presentation from Alex, who will be joining the panel. And our last talk is from David Hargroves, who many of you will know, of course, in his national lead role for GERFT, who is one of the editors for the new chapter, and he's going to cover COVID-19 and thrombectomy. Thanks, David.
Great, thanks very much, Gary, and good evening, everyone. Pleasure to be here and to have co-authored this chapter with Wazim and Norman. So I have no relevant conflicts of interest to declare. So Martin, there we are, wonderful. What I'm going to describe is summary of the chapter that we have produced for this second edition, outlining some of the key themes of the chapter. To highlight, really, to start with the pathophysiology of COVID and how this impacted upon both stroke admissions, but also mechanical thrombectomy. I'm going to talk a little bit about the NHS England's policy changes as a result of the pandemic, talking a little bit about the infection control and streamlined regional pathways that we've all had to learn as a result of the pandemic. Alex has already alluded to what the optimal imaging pathway is, and of course we have that now as national policy. I'm also going to allude to something that Martin has spoken about before about the optimal pre-hospital assessments and improving sensitivity and specificity. And then finally, concluding with some work that the GIRF team has done regarding the optimal reduction in door-in, door-out times. And then finally, a note for the future regarding data quality and improving thrombectomy access as part of a collaboration with specialized commissioning and the pairs collaboration, looking at mechanical thrombectomy quality reviews. So the pathophysiology of COVID, there's no doubt that ever since we were affected, and we first knew that in December 2019 that there was an atypical pneumonia in Wuhan in China, and then the first case that we had in the UK at the end of January 2020. Of course, the WHO declared a pandemic emergency in the second week of March 2020. And then we had the first partial lockdown in starting on the 23rd of March 2020 in the UK. Now, originally, we thought that COVID-19 was a respiratory disease. And since then, we've known that the SARS-CoV-2 virus binds with the angiotensin converting enzyme 2, blocking the renin-angiotensin-aldosterone pathway. And we know as a result of that that we get endothelial damage, we get activation of the endothelial pathways that leads to increase in D-dimers, fibrinogen degradation products, we get relative thrombocytopenia. And as a result of that, multiple studies across the world have confirmed that we get an increased rate of ischemic stroke with those patients suffering COVID-19, unfortunately. It's probably about 10 times that we have seen with standard flu outbreaks previously. And we've also seen from multiple studies that we tend to get younger patients that suffer with large vessel occlusion. And also they tend to be in rather atypical sites as well. So with this in mind, it's rather surprising and a paradox that across the world, we saw a reduction in hospital admissions during the initial first wave of COVID-19. The slide you can see on your screen at the moment is a reproduction of work by colleagues from SNAP, looking at weekly admissions to English stroke services. The dotted line at the top is the predicted level of admissions, and the mauve line at the top is actual admissions from ischemic stroke. And so you saw this really quite significant drop during the first wave in admissions to hospital, English hospitals, about 12%. Now, we also saw across the country and also worldwide a reduction in intravenous thrombolysis use, but also mechanical thrombectomy. And probably in mechanical thrombectomy, worldwide there was a reduction of about 20%. So why did we see this reduction in admissions to hospital? Well, there's probably three common answers to that, and it's multifactorial. But the first one, of course, is that our population was scared. They were worried about coming to hospital, and some patients would certainly have feared for calling 999 and getting to hospital. The second, of course, in England is that we had a very proactive response regarding keeping community patients at home and not wanting to burden healthcare services. And then finally, another plausible explanation is that the COVID infection for some patients masked their neurological sequelae, and therefore some patients who did actually have co-infection with COVID and a stroke were masked, and therefore we did not spot them early enough. During the pandemic, we had a series of guidelines and policies that were introduced. The first from NHS England, RCP, and NICE, really asking everyone to adhere to the core basics of stroke care. That's early imaging, that's early access to intravenous thrombolysis and mechanical thrombectomy, dedicated access to stroke units within 4 hours, and swallow screens. It was in a collaboration between Gary's team and the GERF team regarding how do we actually adapt stroke services, how do we restore and recover them, ensuring patient safety, staff safety, but all that attention on those elements of the hyperacute pathway that we know saves patients from both mortality but also significant disability. There were several schemas that were included in those documentations, and I've put one on the screen here for you. One of the key outputs really is the need to suspect patients of having COVID early and to have rapid testing available, and to really dominate that testing almost for those patients with a low threshold of having COVID, so that you can securely care for them on a bay which is clear, green, without COVID. It's also important that the staff were had available PPE and were supplied with it and were able to use it. We also know that the ability to cohort patients was really very, very important. When we take access to mechanical thrombectomy, the reality is that even with rapid testing, many patients would not know, or the staff caring for them would not know their COVID status at the time of thrombectomy. And it is not plausible to have two separate angiographic rooms available, one for COVID positive and one for COVID negative. So there does need to be a rapid cleaning protocol in place. The other change that we saw during the COVID pandemic is the need to ensure that there's negative pressure ventilation within our angiographic suites, and ensure that if there's any debate about a need to transfer from local anesthetic to a general anesthetic, we actually ensure that, or more patients had a GA initially. We also found that the idea of extubation needed to be also undertaken in a negative pressure room, and so therefore there was slightly longer time periods that patients might spend in the angiographic suite when extubation was taking place. And of course, all staff need to be fully protected with PPE, so that's an N95 mask or an FFP3, visors, full-length gloves as well. Now, of course, this all took time, and it was one of the learning that many of our thrombectomy centres had to slowly go through to ensure safety for patients, but also staff. Repatriation, of course, also was challenging, because many patients had to come back to their acute stroke services to a side room for further testing to ensure their negative status. During the initial pandemic in 2020, both Simon Stevens and then Amanda Pritchard and Steve Paris were really concerned about the levels of thrombectomy, and so a national thrombectomy implementation group and national thrombectomy oversight group was set up to look at 5 key domains within the thrombectomy pathway that needed improving during the pandemic. So that's about accountability and ensuring that everyone knew whose responsibility it was, improving the data gap that we had with regard to processes of care, both with the mechanics of thrombectomy, but also referring patients in and access to imaging. We were aware that there needed to be some system optimization, and Martin's alluded to this before, potentially some more thrombectomy capable centres. We know that we've got a deficit of trained interventional colleagues to undertake the procedure. We also know there is a funding gap that needs to be addressed. We also published the National Stroke Service Model, and Alex has alluded to before in the previous presentation about what is the optimal imaging pathway. Well, NHS England have produced a national optimal stroke imaging pathway, and on your screen, the left-hand column is all about access to intravenous thrombolysis and mechanical thrombectomy. And as Alex has already alluded to, the key is to ensure that CT and CTA are undertaken at one sitting for suitable patients, and we do not undertake advanced imaging CT perfusion for those who are in license for intravenous thrombolysis. CT perfusion does have a role potentially for those patients that are outside the license for IVTPA, so patients with wake-up strokes over 6 hours, or those patients with a bleeding diathesis or anticoagulated. And then a salvageable penumbra may well be determined in those patients. And with the cohort of CT, CTA, and potentially CTP, decisions can be made about rapid transfer within half an hour. Now, AI is key components to all of those three imaging modalities, plain CT, CTA, and CTP. And part of the National Optimal Stroke Imaging Pathway is to ensure that there's a senior decision maker right at the start that dictates those patients that go down the left-hand side or the right-hand side of the pathway and whether or not they need to undertake advanced imaging. Now, the good news regarding artificial intelligence is in 2019, only 5% of the country were using artificial intelligence. But since then, we've seen this dramatic rollout, in some senses enhanced by the need we had with the pandemic to rapidly share images, to ensure that we had a lean network. And now we have over 75% of all stroke centres have some form of artificial intelligence. The key benefits is it's a decision support aid. It allows clinicians some support. I don't believe it's diagnostic, it's supportive aid, but it does allow that rapid transfer of images to comprehensive stroke centres between clinicians. And what would normally take 20, 25 minutes to unpick a CTA and a CTP on a console, artificial intelligence can do it within minutes. And certainly, anecdotally, we have centres across the country that have significantly improved their door-in, door-out times with artificial intelligence and rapid communication with their comprehensive stroke centre. With regards to other parts of the pathway that we've learned during the COVID pandemic, there were 2 pilots that started during the pandemic as a direct result from moving their stroke centres away from A&E departments. This was a big step for UCLH and East Kent because they no longer had A&E to support them for their stroke mimics. And as a result, the pre-hospital telemedicine triage project was undertaken, started in May 2020. And now we have over 7 million patients in England that have some form of pre-hospital telemedicine triaging those patients. Obviously, some of those patients, we have seen significant improvements in specificity and sensitivity of the pre-hospital diagnosis, with corresponding improvements in the processes of care for those patients that are taken to their acute stroke centre. Now, these 2 pilots have not assessed whether or not they would be able to send patients directly to a comprehensive stroke centre, but the photonic study, which is currently underway, looking at many centres that have adopted pre-hospital telemedicine, will be looking at whether or not there is this additional benefit and observation that one can select via pre-hospital telemedicine those patients who should be transferred directly to a comprehensive stroke centre. As a result of the work that we learned regarding the COVID pandemic, both with regards to imaging and pre-hospital telemedicine, as part of the GIRF National Report, we published a whole section on learnings from COVID, and there are 9 steps that we would recommend, and they contribute and they work alongside Martin's 6 steps that he outlined before. The first one is ensuring that there's that detailed communication between the pre-hospital clinicians and secondary care. And ideally, this may well involve pre-hospital telemedicine. There must be more that's transferred from the ambulance clinicians to the secondary care stroke team than just the name of the patient and their age. We need some more identifiable information so that we can look at their previous records. We can speak to their next of kin as the patient is being transferred to the acute stroke centre. Of course, we need to meet the patients as they are at the acute stroke centre, and we need to make sure that they have rapid imaging and they also have the access to the National Optimal Stroke Imaging Pathway. AI will allow us to then transfer those images directly to the comprehensive stroke centre, and those decisions regarding transfer will be made immediately. And again, we have seen examples across the country where door-in, door-out times can be significantly lower when these 9 steps are adhered to. As a result of all of our discussions that we've had during the pandemic, the lack of data and the improvements we want to make on a regional basis have culminated in mechanical thrombectomy quality reviews, which are going to be undertaken in the next few months within England. We have 6 communities of practice, which will all share learning from those high volume centres and those less mature. And so those of you working within acute stroke centres and comprehensive stroke centres, you will have hopefully times already in your diaries to attend these. And we hope as a result of this, we can continue this improvement, possibly up to that 8 to 10% that Martin alluded to earlier. So finally, in conclusion, I would like to suggest that one of the key important parts about mechanical thrombectomy is ensuring that there's increased public awareness, and during a pandemic, people do not shy away of attending hospital. We must make sure that there's enough PPE and rapid testing to ensure safety for our patients and staff. We must minimize all delays, and we must ensure that we use innovative pre-hospital assessments and adherence to the NOCIP to improve our access to mechanical thrombectomy. It's been a pleasure speaking, and we'll stop now to take questions. Thanks ever so much.
Thanks very much, David. We'll sort of convene the panelists for questions. As ever, technical problems, we've actually got a little less time than planned, but I think we will sort of stop at 5:15, have a 10-minute break, and then pass on some questions into the second session if necessary. So thanks to all speakers. I've got a couple of questions, and just say to people, you can put your questions either directly to me or to everybody, whichever you prefer, into the chat. Maybe David, just start with you. The common scenario, it seems, with people having transferred for thrombectomy on COVID stages is a lateral flow negative, and you're waiting for a PCR. Okay, you haven't got a PCR result. That's certainly the experience I've had. So I suppose my question is, what is the thinking, and Alex and Phil may wish to comment as well, on the level of FFP that should be used in those patients?
But you want me to start answering that, Gary?
And then we're going to say, and this is, they're asymptomatic from they've not got symptoms suggestive of COVID. So, lateral flow negative, and no PCR result. And I think that's the main situation you find yourself in with most patients being transferred.
Yes, so the recommendations we made is that everyone adopted during a pandemic, dependent on the baseline infection rate, that you did adopt PPE for all of these patients. And that's the safe way to approach patients like this when we don't know. There's nothing worse than both infecting staff, but also the lab as well, if you accept the patient might not have it and you're called out. So that's the recommendations we're making the guide.
I suppose the question is, what's the level? I mean, I see INRs making their own choices, going for level 3.
Well, Phil may talk about exactly what happens in his unit, but we recommend that it is full PPE and N95 FFP3 for patients until you have a confirmation of a PCR that suggests that they are not infected, which, as you say, is very rare before they actually go to mechanical thrombectomy, but possible.
Alex or Phil, did you want to add a comment on that?
Yeah, that's certainly what we did once those masks were available. I have to say that those masks were not available at the start. We all know about that, and that was a problem, and that did cause anxiety and difficulties, but now they're available, we would do that. However, there is a problem with the room, and it's something that we have yet to really address, which is the infrastructure we're trying to perform. And you'll hear more, I think, from Levan and the Royal London about this issue of trying to operate a 24/7 high volume thrombectomy service on one room. Is if the patient still doesn't have a PCR result and they've gone through as a potential COVID patient, the room needs to be deep cleaned. And that takes the room out of action for 45 minutes, if you're lucky, an hour and a half, if you're unlucky, that room's not available for other patients, including another acute stroke. So realistically, it's a great proposal, and it's what we should be doing. But in order to get proper cleaning, if the PCRs don't come back as quickly as you'd expect, so for the sake of a 20 or 30 pound PCR test, we could omit doing a thrombectomy that could save the NHS, as Bob said earlier, £46,000. It's the usual problem that sometimes we penny pinch where it really shouldn't happen. And we possibly need to really look at infrastructure investment as a one-off to deliver consistent service availability even in 24/7 centres, are struggling with it, I think, in a pandemic environment, because if we don't get another variant that comes, we'll probably get a different disease altogether coming, avian flu or whatever it is. But I think we can't sit on our hands and assume that no more pandemic problems will arise and that everything will go back to normal. So I think I absolutely agree with David. The only downside of that approach is that if you don't have the PCR by the time you finish the procedure, which can take as little as half an hour, or sometimes even less, then you've got to do a full deep clean, and that is trouble. That is a problem. Great,
that's very helpful. Thanks. Alex, can I ask you a question around sort of vexed area of basilar artery occlusion? Do you think CT perfusion, I know you can cover it, has a role in patient selection for basilar artery occlusion, particularly outside the 6-hour window?
Yeah, well, there's a recent paper looking at cerebral blood volume in patient selection for basilars. So it can be handy. What I've noticed recently, and we've had a few basilars come through, is it can be, there's some technically, I think assessing the pons is still challenging with CTP, just because of the streak artifact you get from the temporal bone. So it's not an absolutely perfect tool for it, but there is, I think, it's something that we should explore, and really it's another study really going forward. It's something that should be employed in an RCT going forward, and I think that off the back of an observational study that came out, I think it is being used in one of the proposed trials for basilars. But I just wanted to reiterate a point that I made in the talk, and something that's been sort of reaffirmed by a couple of cases that have come through our unit recently, and that is that I'd really like to sort of drive home the point of, if you've got someone who's got unexplained low GCS with a relatively normal, often not normal, but what's reported as a normal CT, please, they need a CTA. Because it really is a sort of common scenario where we get a patient with who comes in with a depressed GCS, often with a stuttering onset, and they may be misdiagnosed as having a strange encephalitis or another. Sometimes they present with seizures as well, so that can confuse the clinical picture. And in retrospect, there's a dense basilar on the CT. But if the patient had just had a CTA as part of their acute neurology workup, we'd have seen that was the target, and that's what would needed sorting. So yeah, I'd just like to drive that home. But yeah, I think CTP increasingly will have a role for patient selection for basilars, and particularly the cerebral blood volume map, and that's been shown as pretty useful.
Yeah, thanks, Alex. I completely agree with your comment about doing CTA. And I often say first ever seizures, even who are a bit drowsy, do a CTA. And obviously in BAO, you've got this problem that the myoclonic jerks, they get misinterpreted as seizures, and it's really sad when they're missed. Just a question to Martin on the door in, door out times. This is from Phil, actually, but I was going to ask a question. I mean, really, it's saying, rather than looking at the, where, centres are, couldn't we just actually serve most of the country very well if we just really got serious about sorting out door in, door out times and got those down to an hour? And I guess, David covered a little bit of this about the things we can do to improve door in, door out times, but just any reflections on that and the sort of key issues to focus on in, door out?
Yeah, I wouldn't argue with that in principle, really, Gary. I think, in terms of what is there that we can do in the next couple of years that's going to substantially improve the population benefit from thrombectomy. I've listed some of the measures that will come in the pipeline, the development of new sites, new centres and so on, but something that we can do about door in, door out time immediately, in effect. I think, in effect, a national campaign over the next year to get door in, door out times down to 60 minutes would have the most immediate impact on population benefit. There's lots of barriers, of course, in the way of that, not least what our ambulance colleagues say about inter-hospital transfers. But that needs to be the focus about what we can do. I don't think that would completely neutralize the argument for new centres. And the modelling that we did for NHS England was based on a net delay from drip and ship model, a net delay of 60 minutes, which would still sort of accommodate door in, door out time of 60 minutes plus a transfer time. There's some efficiencies at the receiving site, but there's still a net delay. So I think there is still a need for additional capacity, but that would be greatly helped, particularly in the short to medium term, by a real attack on dido times.
I'm going to ask one more question. Thanks, Martin. And then we'll have a break. Phil, I know you couldn't recover it, but I suppose views on the role of IV lytic after thrombectomy and, you know, different degrees of recanalization. I mean, obviously, I know this is a sort of subject of ongoing trials. We've had a recent trial report, but particularly in people who've not been given a lytic, is there a role for that now, do you think?
Yeah, I mean, it's something that there is one Spanish RCT and possibly a Chinese one as well are looking at. There's possibly a role for a pragmatic trial to look at it in the UK or elsewhere as well. Yeah, it's very interesting. Is there anything to be gained by giving thrombolytic? Because we do know that you know, shifting people from 2B to a good 2B or a 2C or a 3 on the TICI, the more nearer you get to complete reperfusion, the better. There's some evidence about the silting up at the very small vessel level that might be helped by. So yeah, it's something I've done occasionally in individual cases, give adjunctive IA, even though they've had IVT. But yeah, to do it as a more routine policy in people with a reasonable but not a TICI-3 result would really, I think, require appropriate RCT evidence to do. In terms of the advantages of tenecteplase, we know that there's some preliminary evidence that it's better than alteplase in association with thrombectomy. But again, there is more work ongoing, and that really needs to come through. And we'd be good to know more about a test too, and what happens with regard to tenecteplase in general as the IVT agent, because there's more to come there. So I think the message should be IVT, if they're eligible for it, is very important still. And of course, the door to needle time focus shouldn't be lost in all of this discussions about thrombectomy. But if they can't have IV thrombolysis, thrombectomy is a fallback for some patients, but not everybody. But yeah, I think in terms of adjunctive use around thrombectomy, it's definitely one that requires formal RCT evidence, because there are some potential hazards, and particularly as we get braver and venture more distally into the cerebral circulation, the vessels are much more prone to perforation and rupture and potentially catastrophic consequences. And the rate of that happening goes up almost exponentially from the ICA to sort of M3 or P3. So yeah, you did a note of caution about it, but I think a good place for further RCTs. And the UK could potentially contribute usefully in that area, especially now we've got a few high volume 24/7 centres coming on stream.
Great, thanks everybody. We'll have a 5-minute break. A couple of questions I can take forward into the next session. I would suggest you don't sort of leave the meeting, just put your video on, turn it off and mute, and we'll start again at 25 past. And again, for any of you who've just joined, you know, we will have a Q&A session at the end of the next 3 presentations. Please put your questions in the chat, either to me or to everybody. And the second part, we've asked people who've implemented thrombectomy to give brief talks about that, and if any learnings they had from the first guide. So grateful to for our first set of speakers, a double act from Royal London, Levin McAlander and Ollie Spooner. So Levin and Ollie, over to you.
Thanks very much, Gary. So my name is Levin McAlander. I'm the clinical lead for interventional neuroradiology at the Royal London Hospital. And I've asked Ollie Spooner, who's our stroke lead for mechanical thrombectomy, to join me, because a lot of the workup and the protocols were designed and written by him. and my other colleague, Paul Bogle. So I think it's a double act because mechanical thrombectomy in whole is a team effort. So we're talking about how our service went across the guide. So looking at the teams from the beginning, the clinical team is really important. Both the stroke team and the emergency department have a big role to play. As radiologists, we have no sight of beds, and we need that and the clinical aspects of the care, which are face-to-face with the hub and spoke. So Ollie's colleagues deal with that at the front end before they refer on to us and how to treat. The next set of team that need buy-in are the team in the IR suite. It's not just the nurses, the radiographers, and also the support staff that are required. And then the final major buy-in is from the anesthesia department. If you don't have the anaesthetist on board, the whole service can run a cropper pretty quickly. And last thing I also should mention is radiology as a whole, not just the interventional neuroradiology group, but the diagnostic neuroradiologists. With the number of CT scans and CT angiograms going up exponentially, we need more diagnostic colleagues in order to fulfill this service and make sure that the diagnostics are up to date before we can do the fancy stuff. So our network growth initially in 2020, at the beginning of the pandemic, we started a 7-day service and the population we served was just northeast London. We managed to do just shy of 100 mechanical thrombectomies with 4 spoke hospitals. Since we went 24/7 on the 30th of November 2020, suddenly there was a big uptick in number of spoke hospitals, initially Kent and then South Essex and then North Essex, so eventually the whole of East Anglia as well. So we now currently serve a population of about 7 million people. We did about 250 mechanical thrombectomies last year in the calendar year, with 18 spoke hospitals referring in. This was with limited additional staff and actually zero infrastructure investment. And one of the key things which Alex referred to was the AI involvement. And so Brainomics was implemented in our hospital, and Kent already had Brainomics in situ. And that allowed a large network of connected AI for stroke. And I think it was the largest stroke network actually in, sorry, that's gone forward. It was the largest stroke network in Europe. Can't turn back. And that covered 14 spoke hospitals, and this has expanded further into Sussex as well. So having a hub and spoke on the same AI network is really important for the spokes. Is for early detection and triage of potential mechanical thrombectomy patients. For the hub itself, it's rapid image transfer. And we've done some work looking at the different spokes who've had Brainomics and who have not had Brainomics. And I think Ollie can talk to us about that. It's his work.
Thanks, Levan. So this is some audit work we did on the effective AI-enabled imaging implementation we're going to be presenting in a few weeks' time at the British Institute of Radiology Congress. So this is the difference between our AI-enabled sites and the sites that are not. So as has been mentioned a few times earlier today, these dido times are way higher than preferable. And I'd like to point out these are winter pressure and pandemic data set. So with unprecedented ambulance pressures that are still ongoing. However, you can see a big and statistically significant difference in the dido time here at the top. And from an implementation perspective, this has shown itself to be really important part of our infrastructure. So rapid LVO detection, aspects estimation, and crucially cloud image review at our hub, which really cuts down the decision-making time, limiting delays in the dido time. So this is our referrer website. It's open access, and it completely describes the pathway and workflow step by step to the referrer to make it as quick and easy as possible for someone who hasn't referred before. So we have pathways on here for AI-enabled imaging, advanced imaging and without, to streamline the information to the referrer. There are embedded electronic handover forms within the website. So the pathway is designed to be as fast as possible for the patient over convenience to the clinician. So there should be a consultant-to-consultant verbal referral whilst reviewing images to accept in the shortest possible time. Simultaneously, the junior docs at the spoke site are filling in the electronic handover form, transferring in-depth clinical info for safe inter-site transfer. So we did some intensive pathway and QI work, including working with the partner industry to optimize care flow and the patient pathway. We assessed the current performance first, then streamlined and mapped the entire pathway with production of detailed pathway maps to drive visibility, consistency, and implementation from referral to post-procedure care and repatriation. So we monitored progress, we created a stroke dashboard tracking the key performance metrics within the pathway and responded to metrics for regular QI cycles presented within governance meetings. And then lastly, we offered education with the creation of improved educational resources, including videos for team members, reviewing and refreshing training materials and SOPs. And so the result of all that work I've been describing, so we reached more patients than ever, so 300% more within a year. And as Levand said earlier, over 250 were completed in 2021. So at the same time, we safely reduced the door-to-groin times by 40%. Crucially, due to the pathway improvements and working closely with referrers, we were able to send external patients back in the safest minimum time, transferring back to their local centre earlier to start therapy with their team earlier, be close to loved ones and home. And this also relieved pressure on the HASU beds. And I'd argue there's no point looking at a HASU bed number alone with regards to capacity, and repatriation time is arguably more important, as shown by the fact that we actually did this with no extra bed capacity. And if you look at the months down there, at the bottom of the graphs, we're very proud we did this with, all in a pandemic with 160 patients in ICU. Some of this was the worst part of wave 2. And so this is where the rapid, robust pathways and high volumes translate to great outcomes. So our latest quarterly data showed over 55% of patients reviewed in our 90-day clinic returned to functional independence. That's MRS 0 to 2 at 3 months, which is way above the BAS target I've shown in green there on the graph. So we interview patients directly to collect robust follow-up data. We do this for more patients than any other CSC in London. We're committed to that data quality. And just down on the bottom right there, we are pleased to show our lowest ever symptomatic intracranial hemorrhage rate in Q3 of 0, down from the less than 5% in Q3. Q4 was 0. And I believe this is due to a combination of being a high volume centre with rapid, robust and safe processes, including for post-procedure care.
Thank you very much.
Thank you.
Great. Thanks both for that really excellent presentation and real-world data. And we'll come back to some of the challenges around that in the Q&A. Our next speaker is Matthew Byrne, a stroke physician from Buckinghamshire Healthcare Trust in our region, Thames Valley. We've got a presentation from Matthew, and he'll be joining the Q&A panel.
Hello, my name is Matthew Byrne. I'm a stroke consultant at Wickham Hospital and clinical lead for stroke. Wickham is a DGH in Buckinghamshire. It's roughly midway between Oxford and Charing Cross, and we're part of the Thames Valley network. So we refer patients for thrombectomy to the John Radcliffe in Oxford, who offer a service from 8 AM to 10 PM. But we have the luxury of being able to transfer patients to Charing Cross overnight as well, or when Oxford, when the angio suite's down for whatever reason, whether there's someone just gone on a table or whether it's been serviced. So we're really in a nice position there. I think there are 2 figures that you need to know for the quality of a thrombectomy service from a DGH. One is the percentage of patients transferred for thrombectomy, and the other one is the door in, door out time. So we decided to have a look. Once we've been doing it for a couple of years, from 2016 we started to 2018, we'd had, I think, 14 patients over that time. So we decided to have a look and see what our door in, door out time was. And I asked my colleagues to guess what they thought it was, and they all thought it would be about an hour. But we did the audit, and we presented it at the UK Stroke Forum in 2018. And lo and behold, it was an hour and 50 minutes. And that was a surprise to us all. And when you look at the constituent parts, it was the CT to CTA was the longest bit and the easiest bit to fix. The referral to acceptance isn't within our gift, but the CT to CTA is. It's the longest bit that's within our gift. And we weren't doing routine CT and CTA at that time. That's something that we've got on top of subsequently. There was a network bit about referral to acceptance, and that's where AI can be particularly helpful, I think. Door in, door out, to the accepted door out time, which is from the ambulance service particularly, that was actually pretty good at 15 minutes. So we decided to do a bit of classic quality improvement. So we'd done the audit, and then it was a question of doing the process mapping. So we had a meeting in September 2018 involving our ED. We don't have an A&E on our side, but we do have something similar called a cardiac and stroke receiving unit, which functions in a similar way. So we had representatives from our ED or CSRU. We had radiology representatives. That was a radiographer. We had one of our regional paramedic leads from South Central Ambulance Service. We had ITU involved because patients do sometimes, particularly if they're needing a CTA, they do sometimes need a bit of sedation to keep them still. It's one thing doing a CT and someone is a little bit agitated, but if you're doing a CTA, then you know, it can be more tricky. And of course, the stroke team, including a junior doctor representative. So once we'd had that meeting, we process mapped, we drafted an SOP for how we thought the pathway should look, sent it out, agreed it, and then implemented it. The radiology protocol was written just before that, in February 2018, and we've had that running since then. And one of the things that we wanted to do was have a radiology protocol that was written and owned by the radiology department. And that's since been updated in 2022, so just last month. And I'll show you that shortly, so you can see what that looks like. But that was an important factor. And then we re-audited the following year. We had 20 patients from 2018 to 2019 that we presented at the UK Stroke Forum in 2019. This is the standard operating procedure, and you can see it's divided into pre-arrival, on-arrival, and post-CTA sections. I won't go through the whole thing, and I'm sure the one for your local hospital would be different because it has to incorporate local circumstances. But there are one or two things I thought I'd pick out. We always have a pre-alert, which I think is very important. And then when we get the pre-alert, we put out a 2222 call, the same for cardiac arrest, informs all the stroke team, informs the radiographer, and it informs the porter as well, which is obviously a few minutes. The ward clerk or member of the cardiac and stroke receiving unit admits the patient on our Medway IT system. Again, saves a few minutes. The stroke nurse on duty books a CT scan in advance of the patient arriving, and the stroke physician on call or the CSRU registrar reviews the notes on our Evolve IT system, and they can pre-populate a stroke clerking before the patient arrives. All saves time, and look at any PACS imaging that's previously been done, again to so we don't get any surprises when we do the CT scan. On arrival, we tend to, just one thing I'll pick out from here, you can have a look through, but the one thing I just pick out is that we ask if we think it's going to be a thrombectomy case on the basis of the modified Rankin score and the NIH score, we ask guys to wait until we've done the CT and CTA if possible. There's no guarantee that they'll be able to, but if we're quick with those two, then there's a reasonable chance that they'll be able to wait until such time as we can make a decision regarding a likely transfer for thrombectomy. And then I think one of the key things I'd like to say is that we try and do actions in parallel wherever possible. We'll ask our stroke nurse on duty or the cardiac and stroke receiving unit staff to book a time critical transfer. prior to the patient being accepted by the tertiary unit, if it's a clear case. In other words, if the stroke physician on call is confident that the patient's going to be accepted, there's a clear M1 occlusion and the brain is not infarcted, in a good case, modified Rankin score of 0 to 2, etc. And we wouldn't necessarily wait until the patient's been accepted before putting the time critical transfer in. Although we wouldn't allow the patient to leave as things stand unless we have that acceptance. This is the radiology protocol, and we have a routine CT angiogram if the NH score is 6 or more and the modified Rankin is less than 3, then the CTA is done at the same time as the CT scan. And as I say, this was written by radiology, so they have ownership of this pathway. And then we re-audited, as I say, those 20 patients from the following year. And lo and behold, the median needle time would come down to 60 minutes. And you can see the big reduction from the CT to CTA had come down from 34 minutes to 5 minutes, with similar improvements in CTA to referral time and referral to acceptance time. We've had a network approach from March 2019 with the Titan group in Thames Valley, and we've also had artificial intelligence with Brainomics from July 2020, which have both helped. And you can see our performance in SNAP. We were 7th out of 84 sites from 2019 to 2020. We've gone down from 60 minutes to 90 minutes during that period, and I don't know exactly why, but it just goes to show that it's a constant service improvement. You can't do it once and forget about it. You have to keep on top of it. But our thrombectomy and thrombolysis compare pretty favourably with the national timings and with the pan-London timings within Thames Valley. So key points, 2 figures tell you what you need to know: percentage transferred for thrombectomy, the median door in, door out time. Classic quality improvement program methodology with process mapping is the key, I think. You need to agree a standard operating procedure, undertaking tasks in parallel where possible, underpinned with a network approach, make the most of AI, but the greatest benefit is going to be from old-fashioned QIP and a teamwork approach. Thank you very much.
Thank you, Matthew. Really good perspective. We've often focused on the development of the thrombectomy team in the Comprehensive Stroke Centre, but getting that network working, real system working to deliver the benefits of thrombectomy is absolutely key. And I think you've given a really nice example of what can be achieved there. Our final talk is from Vaseem Izzat, who's interventional neuroradiologist at the QMC Nottingham and was a co-author on the COVID-19 and thrombectomy chapter. That was a new chapter in this second guide. So Vaseem, over to you.
Apologies for this technical glitch. Hi there, my name is Vaseem. I'm a consultant interventional neuroradiologist, and I used to be based in Nottingham till last year, and I'm now up in Glasgow. So it's just to talk about the experience of developing the thrombectomy service in Nottingham. Nottingham serves the East Midlands population, serving a population of 4 million, expanding from Derbyshire, Leicestershire, all the way out to Lincolnshire, with 4 primary stroke centres, Derby, Leicester, Mansfield, and Lincolnshire as well. And so we initially started and made a huge revamp to the services in December 2018, making huge impact, and with study days going around all the hospitals and trying to build a very collaborative network to the way we approach things. Mechanical thrombectomy nurses, making sure all the data we collect is robustly, prospectively collected as well. And as you can see, from 2018 to 2019, 2020, the number of referrals also significantly increased and continues to do so. How did we use the first guide? I think there are a couple of important things, and the first one was chapter 5, was to streamline the imaging pathways. As you have heard from previous speakers, the importance of being able to get CTAs done in a timely fashion, and particularly from a regional perspective, that everyone is doing the same thing from all your primary stroke referral centers. So what we did is we went around all the regional referral centers implemented a direct access CT, CTA protocols in conjunction with the radiographers, came up with direct protocols, which looked identical in terms of the acquisition mode so that all the images could be standardized as much as possible. To satisfy our IRMA guidelines, we set up a direct access protocol for what you would consider as clinical authorization. And this led to quite a remarkable improvement in access to CTA. As you can see, this is the data from 2020 and excluding next day referrals and posterior circulation influx. The majority of CT and CTAs were done identical or exactly at the same time. And the time difference, if you include all the anterior circulation between CT to CTA, was 11 minutes. And this represents quite a significant shift in practice, and particularly to what Alex said earlier with the convoluted pathway of how it goes from CT to CT head. Simplifying things would help a majority of patients. Next, what we also did, one of the concerns that was highlighted was the educational impact on how to train up and to review images. So we held biannual CT, CTA training in person till the pandemic, and thereafter had more online and Teams type of version of things, where the in-person, I think, is probably the most beneficial. It's probably something that should be done in other regional centers as well. Builds up good relations with the entire team, CT, stroke physicians, radiologists, specialist nurses, and it helps a very collaborative approach towards the single target that we are all getting to give the patients the best possible outcome. The next thing we did was to streamline patient journey. And as many of the previous speakers have suggested, the importance of the door in, door out time. And that primarily comes down to two things: the streamlining intra-hospital processes and in also the inter-facility transfer processes. We went around all the hospitals, kept a very regular thing, education across, listened to people's concerns and seeing what particular infrastructure each of the hospitals have with their CT scanners capable of doing certain things, and try to mirror it out to keep everything as standard as possible and to come up with a very collaborative way of doing things. This is some of the data just to show the patient journey. This is data from 2020 and 2019 from prospectively collected data. There were 50 time metric points collected in approximately 50 time metric points and other data points for all our thrombectomy patients from 2018 onwards. And this is just the data to give you the median door in, door out time. So as you can see here, there are a couple of areas where we probably can make some difference. So the patient journey times, that's not going to be something that can be particularly changed. The one thing that we could change from when you send the accepted referrals to the time patients were accepted, it's usually called an IFT2 transfer, which the median time is 18 minutes. But in reality, as you can see from these boxes from the 4 primary stroke centers, it may be a lot further along than we think. So to address this, we had collaboration with the East Midlands Ambulance Service, came up with a protocol to try and minimize the transfer times and to try and mitigate some of these issues. And the final thing from the guide to talk about was, one more thing before that. A lot of my colleagues previously spoke about was the impact of AI. Now, from the time of when the CTA is done to the time the referral is sent, to the time the referral is sent to being accepted, as you can see here, there's still about a 35 minute gap. And this is, I think, the point where AI would make a huge difference, and implementing AI systems can bring this down to less than 5 minutes, and making small differences and shaving off times in the entire door in, door out times would make a huge difference and impact to bringing it below the 90-minute mark. And we should be aiming for less than 60 minutes mark, which I think is quite achievable by trying to shave times here. And finally, to the last thing of the thrombectomy plans, this particular slide, which was showed earlier, and it's been updated on the current guide as well, was very useful in actually identifying, say, Nottingham was covering a population of 4 million. It's just to give you an idea of what the exact figure of the population of thrombectomies you are. That would help to develop the business plans, doing it and setting up the actual infrastructure required, and making the business case for getting the adequate staff to make sure that this is a sustainable service. And I note that in the next guideline, one of the key points that's been mentioned, and one of the points that was mentioned in the text of the document, is that to make it financially break even is to try and achieve 30% at least, and probably try to mitigate all of that in the future. This kind of picture was particularly helpful. And I shall stop there. Any questions?
Great. Thank you very much, Waseem. Again, really great to see how you approached that and the work that was done. So we're going to open up now to the second panel discussion. As I say, do put your questions in the chat if you have any. We've got good 15, 20 minutes for discussion. The link to the updated guideline is in the chat if you've not picked that up. So you can get a copy of the new guideline from there. I'm going to start with, I think, an interesting question that came earlier, and then we'll get into some questions around AI, where I anticipate a more lively discussion. So there's a question from one of from Rebecca Hyde about what are the panel's thoughts about external centres reporting CTP. Now, I know Alex isn't here, but we've got a couple of INRs, and obviously we've got people in PSCs. And are we ready to start to think about that? I suppose you can also say, do the AI tools have a role here? But if we're going to select patients in the late time window, every analysis I've seen shows only a minority of patients in the late time window have a suitable imaging profile. So ideally, we would image them and not transfer them if they went for thrombectomy. So just some thoughts about that particular aspect. And obviously, we focus very much, as Martin said, on that early time window population because they're the brunt of it. But increasingly, we're going to be thinking about the late time window. We're going to be have to using CT perfusion probably in most of those patients. And I'm open that to whoever who wants to contribute to that. Okay, I'm going to start with you, Waseem. What's your view on that?
I'm quite in favor of CTP, and I think AI has a role in it. And I think if we would make it quite, time is of the essence. So yes, I think that would be something sensible that we have to explore and develop perhaps a standard operating procedure to actually account for limitations.
Levan, Phil, any thoughts?
I think the old chestnut is the difference between immediate action on the scan for the patient benefit and the subsequent reporting of it. I think the former is much easier to sort out, and the AI tools can certainly help, and particularly those that have been tested thoroughly. Rapid is the one that stands out for CT perfusion in randomized trials. We've now got a pretty good understanding of strengths, weaknesses, and so on. Some of the newer tools from other AI companies have not been evaluated the same way, so further evaluation needs to be done because they're not all the same. I think it's a little bit more difficult when it comes to subsequent reporting of a study. You can take the line, if you like some people have done for plain films, of not having a report at all on the CTP and just deal with it acutely and not get a formal report, and that's one solution. You could outsource it, and Alex went carefully over a number of different potential scenarios, and I think one size will not fit all, and probably there are a number of solutions that are possible for it. So I think one route for everybody won't work, but there'll be multiple ways in which it can be done. Some areas may have capacity to take on such reporting. In other places, it'll need to be outsourced. In others, it may be dealt with in-house if people build up the local expertise. And we have altered the Royal College of Radiologists training curriculum to bring CTA fully into the curriculum for stroke, and that will work its way through. The similar thing could be done for CTP, and likewise for training of stroke physicians and others involved in the pathway.
And certainly, we're seeing now my centre the stroke physicians are routinely looking at CTP, obviously not reporting it, but increasingly we're making our own view on that. Of course, I thought Alex's point he made, I thought was really interesting, that if you've made a decision to transfer, you don't need an urgent report, because clearly the interventional neuroradiologist is going to be looking at the scans. It's not here nor there, but it's those who have a negative readout on AI which, you need the urgent report if in fact it's a false read. So I think that it's kind of an interesting evolving area. I'm just conscious of all the work we have to do to get CTA as routine in the referring centres and the work that's going to come with that. But I suppose it will just come as the scanners are upgraded and it will become easier. Okay, any other reflections on CTP? Matthew, what's your view as a referring?
I mean, we've managed to get CTA 24/7 now. CTP we're still struggling with. I think one of the problems in a DGH is that there's the lack of experience among the radiologists for reporting it. There's an inevitable nervousness amongst taking it on. And yes, I mean, Phil's right, we could outsource the CTP imaging for the cold report, because the hot report would be done by the acute physician AI in combination with the tertiary centre. As the cold reporting is a sticking point, it could be outsourced. There will be a financial consideration there, but that's perhaps the solution. I hadn't thought of not reporting at all, but I guess that's another option.
But certainly the sort of centralised reporting probably makes sense, but it does need resourcing, and as been talked about, diagnostic neuroradiology is still an issue in itself. I'm going to move on to AI, and I'll declare I don't have a financial interest in it, but my organisation is doing a real-world evaluation, and we use Brainomics in my centre, and the colleague George is very closely involved with Brainomics. I find it extremely useful for external referrals, and certainly my experience is I can get the call from Matthew or somebody, I can open up, I can see the images through the cloud, and whilst I'm still on that phone call, can make a decision whether to transfer in the vast majority of cases. But I suppose my question is, and there's various comments about diagnostic accuracy, which Phil has pointed out, and I listened to the NICE Diagnostic Committee assessment of brain imaging last week, which was very interesting. I was there just as a public observer. But to what extent actually is most of the benefit we're seeing of AI, and there were some really nice examples, simply just the cloud-based function of it, rather than what it's actually doing, which is the AI read of the imaging. And I'm kind of interested in, everybody here will have got experience, so just interested in a range of views here. What I would say is I was fascinated by how the NICE discussion focused very much on the diagnostic accuracy and not about these other advantages. And I still remember having to refresh the screen to wait for the PACT images to come. And I'm thinking, well, how about costing in all the time I'm there, which is very expensive. So it's not, to me, it's not just about the diagnostic accuracy, because we don't have a proper cloud system routinely in the NHS system. So, I mean, clearly this is an evolving area. The tools are going to improve, and I'll be radical and say AI eventually, because it's just looking at a black and white pattern, will be as good as any human observer. It's nowhere near it yet. So, but at the current state of affairs, what do we think about AI? Are we looking at it from the wrong prism when we look at it as a diagnostic accuracy? But anyway, just open up that for discussion.
Yeah, can I say something? Yeah, I completely agree. There's way too much focus on the ins and outs of accuracies, and it's at the end of the day, it's a decision support tool for the physician, and it should be there to speed up the whole process. So if a physician at that end can get a very rapid aspects estimation with LVO detection whilst they review themselves, and then for us it's been invaluable for the image transfer. It's the IEP is just so unfit for purpose, and it's so variable throughout the day. So if a scan in the middle of the night can be quite quick, but in the middle of the day when there's tons of trauma scans coming through, or it gets stuck in a bottleneck, and it could be an hour or more. And so it's really I think it's as a decision support tool and to save time, it's great, and it should be rolled out faster to more sites.
The views. I guess the risk here, and what you're concerned about, Phil, is not the false positive reads, because in the end, okay, you get a bit of an unnecessary transfer and you've got a stroke physician looking at it the other end, and it's the false negative reads of an intervention patient. And that was Alex's point. You need a rapid report on a negative AI readout if the AI functions missed it and the receiving stroke physicians missed it. But I have to say, I think our capability at the CSCs, we're looking at so many CTAs now and making decisions and having weekly meetings with our neuroradiology colleagues. I think our capability, certainly in the CSCs as stroke physicians, is improving rapidly.
Yeah, I think there's no doubt about that. And there's lots of tools that people have mentioned, both Wasim and others, about training, and evidence for that does abound. We've done some ourselves. And I think there's no doubt that AI is fantastic for speeding things up. It's an awfully expensive way of accessing the cloud, potentially. Netflix costs, what, £9.99 a month? But it works, and it's networking across a network using the same tool is also quite important. And that was mentioned by the BARTS team. And I think it's worth emphasizing, because that's also important. All the tools are not the same. The rapid CTP is not the same as the Brainomics or anybody else's. They've come from different paths and are in different phases, actually, of evolution. They will get better, and they probably will eventually match human experts. It's interesting when people have looked at it, though, that they're not actually, you think they'd never disagree with themselves. You'd think about everything that AI does, it would not disagree with itself. It's how computers, we think, operate. And in fact, actually, that's not the case. When we've looked at this for CTA as part of the RIGHTS collaboration, which involves quite a lot of stroke professors as well as radiologists, it actually disagreed with itself 20% of the time in CTA. So when it was put back through, it didn't give the same answer twice all the time. So it does have some foibles, but that's not to say that it isn't a fantastic tool and we need to use it, mainly to speed the pathway up. And as you say, Gary, for those who do see a lot of CTA stroke physicians and they've got the decision support tool there, it will be a backup and a help just to speed things up and flag things up. I think there is concern over low volume units with negative results on the AI. Is it truly negative? Because that's the patient that's most to lose, not the false positives. Yeah, just work in progress, so it will get better.
I mean, interestingly, for the patients who present directly to us, because they are looked at by the neuroradiologist fairly quickly, I just read them as they come up on PACS and don't use, I don't use the Brainomics tool then. But I mean, for the referrals, it's absolutely invaluable. And actually, the images are presented very, in an accessible way, which I think is helpful as well, better than what you get out of the standard, sort of output on PACS.
Gary, can I give a DGH perspective on this?
Yeah, please do.
I think most stroke physicians are pretty comfortable reporting a plain CT, and a CTA up to M1, most of us are pretty comfortable. So at the moment, I think it's used as a, have we missed something? Have we missed low aspects? When, have we missed something that we should have spotted? I think the gain will come when it raises to the level where it's able to spot the M2s, which I really struggle with, and CT perfusion, which I have no experience with. That's when it's going to be really helpful. I think at the moment, I agree with you. I think it is the image sharing, and I think that could get better. I think if it can pick up an LVO and immediately notify you and the new radiologist at John Radcliffe when before the patient leaves the scanning table, and then we can have a conversation and you're already looking at the scans and they're already open, then that will be the next step. And I think that could improve things further. But I think, as I tried to highlight in my talk, we should not look at AI as solving the door in, door out door problem, because it will help, but the most of the door in, door out door problem is a systems approach at the local centre, and that's where it's got to we've got to focus as DGHs in trying to reduce the door in, door out time centre.
Yeah, fascinating, Phil, that it disagrees with itself. It's becoming human, it sounds to me, the AI functionality. Any other comments on this?
Deep learning for you.
I've only used one system, so I haven't personal experience using Rapid or some of the others. So yeah, okay. We had a question. It was around the perennial chestnut of what's our current consensus on thrombectomy for basilar artery occlusion stroke. And I guess you're all going to say it's got a role, but interested to hear people's views on time window. Do you use perfusion? What do people think? I mean, Alex covered this a little bit in his comments about perfusion and some of the the challenges, but I guess most of us would accept a previously well patient in an early window, 6 hours from deterioration, with a basilar would plan on having a go unless the CT perfusion was really unfavourable by when they were at the CSC. Any particular perspectives on BAO?
I'll just jump in there. The only thing I would say with that, basilism on top of anterior circulation strokes is ITU bed capability and capacity. So that's another square we need to circle in terms of accepting basilar artery strokes from network. So, yeah, local patients, no problem. Accepting from further afield can be an issue, and it's often ITU to ITU or that capacity which determines what happens. Yeah,
we have to say, interestingly, I have less problems in perhaps because it's neuro ITU getting, these patients sort of transferred accepted. How to get a patient to the general ITU had type 1 respiratory failure with an ordinary stroke, not thrombectomy. That was one hell of a job, which is a sort of general intensivist view of stroke patients in general, let alone basilars. But yeah, I think the ITU to ITU transfer, and I think that is an issue. But I think we're saying, even though the trials have not definitively shown benefit, we think there's a crossover. There's still hard to sort of say we're not going to treat basilars, is my view on this. We've got a question again, the panel's view on thrombectomy in patients with low NIHSS. So I guess we're going to talk about a cutoff of 6 there. Again, Phil, you've looked at the evidence, thoughts on that?
Yeah, I mean, you've got to balance the risk and benefit. And although these patients are generally in quite good status, and they're often still quite elderly, and so many of the risks of the procedure are still there. The benefits, that's why we need randomized control trials. And my other thing is we need to wait for the ongoing randomized control trials to show us whether they truly benefit, because if the absolute benefit is 4 or 5% of the procedure, but the complication rate is not much lower, then the risk benefit is going to be there, but potentially quite small. And you then really coming into how quickly you can treat them, and what's your aftercare, and a whole load of other factors might come into play that we haven't had to worry about at the moment, such as technique, performance in terms of TICI, performance in terms of daughter puncture, and other things. And we could find that one really high volume good unit like Royal London may be fantastic for low NIHSS. A small lower volume centre may struggle to get any benefit at all. So it may be much more difficult and nuanced. But I think we need trials before we can answer this definitively. I mean, at the moment, personally, if it's, do you take an absolute cutoff? No, you'll go on the patient. Ranking 0, person is ranking 0 with a stroke in a very sensitive area, like to the speech center, with an NIH stroke score of 5 or 6, you're going to take them. If it's to a less sensitive area of the brain and the NIHSS is 1 and they're 85 with lots of comorbidities, it's a slightly different nuanced question. So at the moment, personally, it's ad hoc, but hopefully RCTs will give us that information. And as Martin's pointed out, it could make a very big difference to the total numbers. However, it's likely to be not as cost effective. It will be cost effective, but not as cost effective as the 40-odd thousand pounds that was alluded to earlier for current evidence-based thrombectomy.
Yes, I think rather be like thrombolysis, there won't be a simple rule. You've really got to weigh up the risks and benefits in these patients. And, we know there's a definite hazard with thrombolysis in people with low NIHSS, and it's still not really resolved as to who you treat, don't treat. And so I think it's going to be very tricky. I mean, I would move on to a similar area, which I think we will have to address in the future, which is the issue of patients with pre-stroke disability. So obviously the trials have almost exclusively had patients with 0, 1, 2, but we're often seeing patients with pre-stroke rankings of 3, either due to previous stroke disease or indeed more general functioning. And I think whilst most of us stroke physicians are very comfortable treating certainly people with MRS3, and I've treated patients with MRS4 and even one patient with MRS5, which I think was still justifiable after it, and they did well. I think, we will get sort of what happens with any technology, you tend to use it in a wider patient group than the trials. And just interested in reflections on pre-stroke disability and how we should weigh that into the decision making and how you do at the moment. Maybe starting with Matthew and Martin and Ollie, who do the initial assessment.
Yeah, I mean, I think, you know, if the evidence was there to support it, that would be a logical step. And we routinely thrombolyze people with a modified Rankin 3. We wouldn't dream of withholding it for that population. And I think, you know, when you've got a nursing home population, it's a little different. But yes, if the evidence would support that, then that's something we would be keen to do, I think.
I mean, such a big treatment effect that certainly with patients pre-stroke MRS3, I feel quite comfortable in general in referring, referring those for intervention to our colleagues. I think 4 and 5, you've got a complex issue. They're going to have worse outcome, and you're into the cost effectiveness issues in a way we're not with thrombolysis. I think it's easy. Very little data on MRS 4 and 5. I've seen review papers with patients with MRS 3 and 2, but and they show favourable results as you'd expect. But I think down at the bottom end, I think we probably still need to be more cautious.
From our perspective, yes, we do treat patients above to a case-by-case basis, taking into account what exactly why the MRS is that number. Is it actually frailty, or is it something else like that they need support for? I don't know, for another reason. But yes, I guess if we were to relax our guidelines and referral guidelines for external sites, we'd have to think about, I guess, how we'd report it as well. So we report our data to the Pan London group, and we report our 0 to 2 at 90-day figures, and we'd have to think about how we report them if we are taking pre-morbid patients of 3 and above. That's something we'd have to take into account. And also, I don't know if other centres must have this problem too. Sometimes at the point of referral, the MRS turns out to be very different when they arrive than what was told you. They seem to, we sometimes joke the MRS goes up every 10 miles on routes, and I guess there'd be a concern if you relaxed it that your MRS of 3 would actually be closer to 5 or inaccurate. But just some thoughts, yeah.
Yeah, I sometimes wonder whether we need the accepting centre to be able to dip into the patient's full medical record to look exactly what's happened before, because it gives you a very helpful perspective, of course, from previous consultations. And most stroke patients have been under hospital care before in our experience. Martin.
I just make an observation from our numbers chapter that, in fact, moving the threshold for modified Rankin has relatively little impact on the overall numbers treated, and that's probably because they also come to hospital with other exclusions, or there may be those who present more late, or those who have adverse imaging criteria otherwise. So I think probably we need to be careful not to be hung up on whether there's a strict implementation of a modified Rankin threshold just because we know it has relatively little impact. I think the priority for a lot of centres, of course, we're on the panel, we've got busy centres by definition, but the priority is getting centres that are not very active with the big M1 occlusions and getting them up to speed. And it may be when an issue of study design, when we come to talking about a randomized controlled trial for distal M2 or M3 occlusions, it may be that you can earn your right to randomize people with distal occlusions by hitting a particular threshold for activity in the proximal middle cerebral artery first. And of course, there will be a learning curve and a technical curve in getting to the smaller arteries. So I think if one were to do a study in lower degrees of NIHSS, it would have to be strictly defined according to institutional competence and familiarity with the techniques.
Oh.
Yes, just one comment further to what Martin said about the numbers. Dwarfing everything else, which he hasn't really emphasised, which is in the paper, is the ageing population and that impact on thrombectomy and the numbers eligible. It dwarfs everything else we've talked about. We could see a doubling of the numbers eligible by 2040, at least doubling, based on the current ageing profile of the population as predicted, unless we're extremely successful in primary and or secondary prevention.
Yeah, I think we're getting better at it. I mean, one of the things I'm picking up with David Hargrove and Deb Lowe is, can we improve lipid management in the stroke pathway for TIA and stroke? Because we don't really look at it assiduously. I'm an optimist. I think we will get better CVD prevention. And some of the projections we had early on in the 90s about what would happen with stroke numbers have proved to be wrong. But I still think we've kind of hit a nadir of stroke numbers, and it's going to go up from here, whatever we do. So I think there's a point well made. I think we should close. There was one question I haven't addressed, but we're 1 minute over. So I'm going to thank all of our speakers today and panelists, thank my co-editors, and obviously all the authors. And I'd like to thank Gemma Goff for the editorial assistance she's given. We hope this has been a useful webinar, and we hope you find the guide useful. My final comment is we did the first implementation guide in 2019. We've done the second in 2022, and we haven't seen much progress. I'm hoping by 2025, when someone says, should we do another implementation guide, I'll say, no, it's done. We've got 9% of people being treated, so there's no need to do an implementation guide. We just leave it to GERFT and the sort of tough end of regulation to sort it out, because that's where we want to be. So good luck to everybody. This is a good time for getting thrombectomy access improved. I want to thank everybody, and have a good evening.